Let's get started. Hello and welcome to the Women's Heart Health webinar sponsored by the Women's Caucus of the California Applicants Attorneys Association. My name is Heather Harper and I am a member of the Women's Caucus, also an applicant attorney representing injured workers at Butts & Johnson law offices here in San Jose. I will serve as moderator for this webinar. We have with us our featured speaker, Dr. Susan Zhao, well-respected cardiologist and Associate Chief of Cardiology for Santa Clara Valley Medical Center here in San Jose, who will discuss the science of cardiovascular disease and its unique impact on women and what we can do to prevent heart disease, along with recognizing the difference in heart attack symptoms for women as contrasted to men. We also have fellow Women's Caucus members and applicant attorneys Joy Delakia of Delakia Law Offices in Placentia, and Cheryl Lamb Silverman of Silverman and Lamb Offices in Orange County, who will share their personal stories. In this webinar, we are going to learn about the primary cause of death for women, how women can take steps now to prevent cardiovascular disease, along with recognizing the signs and symptoms of heart attacks in women and how they differ from men. We will end with a live question and answer session with Dr. Zhao. Dr. Zhao, can I turn it over to you?
Of course. Thank you, Heather. Let me share my screen. And can you all see?
Yes, it's not quite full screen. Are you
Yeah,
able
I'm going to turn
move?
into full screen and also swap. This is the, you see it okay?
Perfect.
Okay.
Yes.
All right. Thank you all for attending this webinar. I'm so honored to be here to share with you my perspective, both as a practicing cardiologist and also as a woman. Share with you some of the things we've learned, some of the things we know, some of the things we don't know about women's cardiovascular health. So go back to the beginning of the slides. I've been working at Santa Clara Valley Medical Center, also affiliated with Stanford University School of Medicine since 2011. I'm a practicing non-invasive cardiologist for the past 12 years. And I have no financial disclosures, so I may be touching on some of the devices or products or medications, but I'm not on any speakers bureau or advisory board of anyone. So it may be confusing. You may hear both in the medical literature and also in the general media about all those terms got thrown around. Coronary artery disease, coronary heart disease, ischemic heart disease, cardiovascular disease, and then lastly, a big umbrella term, atherosclerotic cardiovascular disease. So they, by and large, the first three, they just mean the essentially the coronary artery system. That's the blood vessel network that supplies blood to the heart. And then cardiovascular system is a little broader. It includes not only the coronary arteries, but also the heart as a whole organ. And lastly, ASCVD as a big umbrella term encompasses both heart disease and also vascular disease, including the arteries in the rest of the body, the carotid arteries, the arteries in your brain, and also stroke. So you probably have heard that cardiovascular disease, despite the past 30, 40 years of advancement in medicine and devices, remains the #1 cause of death for women and men. So right off the bat, I would like to bring out this analogy of the heart and your house, right? So the most we heard about the house, the heart is the coronaries, the heart attack, the angina, the symptoms. But you need to be aware that the coronary artery system is just one aspect of the heart health. In addition to the arteries, there are also other components of the heart that can impact your cardiovascular health tremendously. The analogy here is that the coronary arteries, they're the plumbing system of the heart, and you also have the electrical system of the heart. If that goes awry, you're going to have arrhythmias, either really fast heart rate or irregular or a slow heart rate. And then you have the pumping chamber, the motor of the heart, which is the heart muscles. If the heart muscles are damaged in any way, you end up with heart failure symptoms. Last but not least, you have the valves. They're almost like the doors, the windows, the hinges of the house. If the hinges are blown, the door is ajar, the window is blown open, gusty wind. So this is, of course, a very oversimplistic view of the heart, but give you a general framework of, the coronary being the plumbing system, but that's not all about the heart health, okay? This diagram is very commonly shown to show you that the progression from a healthy artery to the final stage where there's a big bulging plaque of blocking flow, and with acute rupture of the plaque, plugging up the flow entirely, give you acute heart attack. So the fatty streak part starts as early as teenagers, and studies have done autopsy studies in military recruits. Young military recruits died suddenly during training, and they are like 18, 17 teenagers, and they already developed fatty streaks in their arterial wall. And so that's as early as, in the teenager years. I mean, people attending this webinar, I'm pretty sure most of us already have this inside our arteries. They are no longer very smooth. Over time, if there's age, there's cholesterol, there's diabetes, there are dietary indiscretions, there's smoking, there's genetic components to it. Some people will develop a buildup of those atherosclerotic plaques in the inside wall of the arteries, not just in the heart. It could happen anywhere in the arterial system in the body. And at this stage, people will not be having any symptoms, and you're just happily going along your daily life. It won't give you any grief until it's about 50 to 70% blocked. And then when you exert yourself, you need a little bit more blood going through. And guess what? The blockage prevents adequate supply at the time when you have to augment your intake. So that's when you have little, angina. I have little time here when I'm going upstairs, when I go on like 5-mile hike, and when I'm running after the bus, or when I'm extra stressed at work, I may have a little, chest pain right here. So that's more of a chronic symptom. So when it happens, that the plaque acutely ruptures, that sets aside the difference. That's no longer a chronic angina. That's acute heart attack. And Heather just asked me before the beginning of the webinar, how can we tell which plaque is prone to rupture and give you acute heart attack? And we still don't know. That's a very hot area of research. But I think this diagram really illustrates the progression of the atherosclerotic process and the difference between chronic angina symptoms and acute heart attack with, very can be very severe chest pain or pressure or tightness, or can be atypical, like indigestion, sweating, short of breath, and some people could have very minimal symptoms. So this is what people come to the hospital with acute heart attack is suffering. This is underlying pathophysiology. Okay, women, in general, women are protected by their hormone. That's why they present with heart disease, heart attacks, and angina about 10 years older than men. But once they hit 65, the risk become equalized. And younger women do have heart disease and heart attack from a variety of different other mechanisms than acute rupture of plaques. And so they're more likely to wait before they present to medical attention when they do have symptoms. And they're often referred less for testing. And when they do present with a heart attack, there are more complications and increased mortality, probably more due to the delay in treatment and diagnosis. The symptoms of ischemia, I think this is the audience of this webinar are very interested in, is, we all know that women and men, they may present with different symptoms when a heart attack hits. It turns out there are more similarities than differences in symptoms. First of all, symptoms are very subjective, right? So you may apply the same physiology, same event to different people of the same sex, right? Women, they may perceive and interpret the same symptoms differently, just because your threshold and your interpretation, your perception may be different from not just between men and women, but also between people of different level of health literacy, different level of socioeconomic status, and different degree of social determinants of the health. And they may interpret the same symptoms rather differently because it's very subjective. So I would like to bring out here that we've done studies in the symptoms, and older studies tend to say that women are very different from men. They usually present with atypical symptoms rather than the classic Levine sign, which is you have a fist on your left chest and you're having excruciating chest pain or chest pressure, or elephant sitting on your chest. Those are classic textbook symptoms, but not everyone reads the textbook when they have the heart attack, and not every single man or women. We've seen a lot of men presenting with indigestion as well. So women are not unique in that they may present with atypical symptoms. So these symptoms may be the classic pressure, right? Squeezing, tight, pressure, something is sitting on my chest, being hit, being kicked by the ball, like being pierced through by arrows or like bullets, and trouble with breathing, sweating, and unusual fatigue or irritable, like feeling just irritable and fatigue, unexplained. Something is not right. Again, just follow on the same line, that because the same symptom may be perceived differently, and there might be a delay in recognizing the signs and symptoms of a heart attack, and a delay in getting care. That may also be some perception from the provider side, right? The doctors may also see women's symptoms as atypical and not classic, right? Not everyone has read the textbook of heart attack before they come into the heart attack with a heart attack. So that may be related to late presentation, delayed diagnosis, lower rate of being referred for tests, and higher chance of having complications when they do get referred for intervention. But they do better with intervention than without intervention. So that's just a whirlwind kind of overall overview of the pathophysiology, the clinical presentation of acute heart attack and the chronic angina in women, but also applicable to men as well. Now take a step back. So we want to capture all of you, before you get to the hospital with a heart attack, right? How do we prevent you from get to the final stage of a heart attack? How do we stop the rolling train before it gets off the rail, right? So that comes with prevention, right? Prevention, that you're going to hear all over again. So prevention is really something we should focus on, not only for individuals, but also from public health, from the population health in general. So that introduces prevention pyramid. The primordial prevention is at the public health level. For example, the public health campaign to stop smoking, to reduce sugar drinks, and to go out and exercise and to eat healthy. That's more at a population public health level. For any individual, if you have never had any clinical disease, heart disease, brain stroke, and you should focus on primary prevention to never progress to the next step. That includes a whole panel of parameters we can follow. Secondary prevention is for people who have already had the disease, either from documented angina, obstructive coronary disease, or stroke, or cardiac stenosis, or heart attack, or heart failure. So once you already have a clinical diagnosis, how do we, what kind of intervention we can do to prevent recurrence and progression? Okay. A last one is tertiary prevention, usually applicable to patients with not only documented clinical proven disease, but also advanced disease, and how to prevent from deterioration from late disease to frequent clinical deterioration, and even late stage and death. So in particular to women, for cardiovascular disease, not only they are at risk for all these traditional factors like smoking, diabetes, inactivity, obesity, poor diet. There are also other unique factors for women. For example, adverse pregnancy outcomes is also a documented and proven risk factor for women. For example, if you have gestational diabetes, gestational hypertension, preeclampsia, frequent premature abortions, or intrauterine growth retardation, the baby doesn't grow well during pregnancy, all those will also put the patient essentially at risk of developing cardiac complications later in life, maybe a decade or two later after their pregnancy. And we also know that hormonal factors play a role once women cross the threshold of perimenopause, the protective effect of the hormone estrogen has worn off, and you will be put on the same footing as men at age 65 average. Lastly, psychosocial factors like depression, anxiety, social lack of social contact, social determinant of health. This is also we just begin to know. Health literacy, education, income, intertwines with the traditional risk factors and the hormonal factors. So that introduces the next big concept. So American Heart Association has introduced this health metrics for primary prevention, dubbed Life's Essential 8. As this infographic shows, it has 8 matrices. That's healthy diet, daily exercise, sugar control, glucose control, weight management, lower your cholesterol, blood pressure control, no smoking. And lastly, this was added just recently. It used to be called AHA's Life's Simple 7. And the 8th matrix was added 2 years ago, adequate sleeping, 7 to 9 hours of sleeping per night, because we know sleeping is a regenerative, restorative process. Adequate, high quality sleeping plays a role not just to cardiovascular health, but in general physical health as well. So I encourage the audience to, it's easily available, just type in Life's Essential 8, and there's actually a detailed description on how to optimize your health on every single item of the 8. Parallel to American Heart Association's Life Essential 8, American College of Cardiology similarly also put out a infographic called ABCDE, is in parallel and very much similar, and a lot of overlapping between AHA's Life Simple 8 and ACC's ABCDE. Here you also have blood pressure, cholesterol, cigarette smoking, cessation of smoking, diet and weight management, diabetes, exercise. And here, only thing extra is, think about whether you need to take a baby aspirin a day for primary prevention. So, feel free to go and offline and check into AHA's Life's Essential 8 and ACC's ABCDE. I like to put this journal article. It actually summarizes the current literature on how much exercise is adequate. Is actually not the traditional threshold of 10,000 steps, right? That's a very high order to achieve, to walk 10,000 steps a day. I've done it for a while, and it gave me, it hurts my knees. I stopped doing it. I have to back off, and if that will give you a lot of consolation to say that actually it's not the more the better. Actually, the optimal step count for all-cause mortality is about 8,700 steps, and for incident cardiovascular disease is about 7,000. So take an average between the two, maybe 8,000 steps a day, and to achieve both mortality benefits and also cardiovascular disease benefit. So I think hopefully this will be encouraging to our audience here. You don't have to be compulsively checking your watch. Have I hit the 10,000 step yet? Have I hit the 10,000 step yet? What if my knees are hurting? I have arthritis. So actually 7,000 to 8,000 steps a day is adequate. And back to the AHA's recommendation is 150 minutes per week of moderate intensity exercise. You are not required to go run a half marathon. You only if you can only do 30 minutes per day of moderate paced walking for 5 days per week, you satisfy the exercise the recommendation by American Heart Association. So and the next question is what diet, right? So and I just put on the New England Journal of Medicine article on a kind of a landmark study evaluating a controlled diet from the Mediterranean diet, either augmented with nuts or Mediterranean diet augmented with extra virgin olive oil, right? You can see this is mind blowing that by simply eating the right food, you can actually achieve the primary endpoint of all-cause mortality and myocardial infarction and stroke by a significant amount from controlled diet. So I want to really put a plug in here that Mediterranean diet, if you can augment it with nuts or extra virgin olive oil, you can achieve the dietary recommendation part of the life's essential 8. Similar thing, what is Mediterranean diet is high in vegetable and fruits and nuts and fish and maybe the red meat at the very tip, and limit that. And there's a pyramid, which means you start from here and go less and less as you go to the top. Yeah, I've been asked a lot. I just cannot shed my weight. Doesn't matter what I eat, doesn't matter what I do, my weight stays the same. I want people to maybe take some of the shame off themselves. And there is a theory of obesity set point, which means your body has just like a thermostat, right? Your body has an like obesity stat. It tends to, with any swing from your set point, the body tends to do everything it can to bring you back to that set point. Maybe you cannot drop your weight. It's not because you're not exercising enough, you're not eating healthy enough, because your set point is set differently. So maybe we can flip the metabolic switch by going on some alternative or going on pharmacological therapy. Again, I have no financial relationship with any of the manufacturers. I just want to, maybe if you cannot make any difference in your weight and your metabolic profile continues to be not in the normal range despite everything you do, maybe it's time to talk to your doctor about intermittent fasting, which is another very popular topic, and also pharmacological therapy for weight management and metabolic management. I think I'm going pretty fast. And how am I doing on time? I mean, doing okay on time?
I think we are.
Okay.
Just go ahead.
All right. Just a few more slides here. So another often asked question, should I take a baby aspirin a day? So the answer is maybe. If you already had a heart attack or stroke, by all means, the doctor will make sure that you're on aspirin for secondary prevention. And if you have never had any clinical manifest disease but you're thinking about it, so you may want to talk to your doctor, and the doctor may put your profile into some sort of accretion and risk estimation calculator. If you're low risk, you may not need aspirin, only if you're risking a high risk, or if you have a high ASCVD risk, or if you have some of these risk enhancers, as well as low risk for bleeding, the doctor may recommend an aspirin. So not for everyone, okay? If you have no clinical manifest disease, you may be considered for baby aspirin for prevention if you fall into this high risk category, or if you're moderate risk but you have some of the risk enhancers and you have a low risk for bleeding, then the doctor may put you on. It's a lot of shared decision making, and so case by case adjudication there. Okay, so it's not automatic. If you're over age 70, it's actually recommended against you being on aspirin. Being why? Because aspirin does cause can lead to higher risk of GI bleeding from the gastrointestinal tract. So it's not a automatic knee jerk. Yeah, everyone over this age, you're worried about it. Baby aspirin, it can cause a lot of harm. If you have a low risk for bleeding, if you have a high risk for ASCVD, or if you have some of the risk enhancers like family history or smoking, or if your coronary calcium score is high, you may talk to your doctor about a primary prevention aspirin, okay? And the next one is statin. Should I be taking a atorvastatin, Lipitor, to prevent me from having a stroke or heart attack or heart failure or carotid stenosis? So here, the indication for primary prevention is broader than aspirin. So all on the green column, if you have disease or disease, yes, it's automatic. If secondary prevention, no question asked. Primary prevention depends on your fasting cholesterol. If your LDL is over 190, yes. If you have diabetes, it's an automatic yes. And if you have these factors, you may also be on a statin, okay? So again, talk to your doctor and see which bucket in terms of risk factors you have and the chance of you developing ASCVD next 10 years. If you're anywhere below 7.5, you don't need it, okay? All right, so it's kind of very fast overview of the pathogenicity of coronary artery disease and different presentations, and what are the measures women can start taking to prevent you from going from asymptomatic preclinical stage to the clinical manifestation of disease. And lastly, I just want to give you a few bullet points so you can take home and think about it and either to do more research, investigation, or start acting on this today's topic. So it is still by far the biggest health risk for women, and women do have additional risk factors not shared by men, such as hormonal and social determinant of health, and other non-traditional factors other than the way the diabetes, the smoking, and the cholesterol. Okay, and women can present differently and be referred less often. There can be a delay in getting diagnosis and treatment. So we need to essentially educate both women and also the providers on women's presentation with heart disease. And lastly, remember, second from last, remember American Heart Association's Life Essential 8 and American College of Cardiology's ABCDE for primary prevention. And last but not least, the coronary disease, the coronary arteries is just one aspect of the heart health. The heart has the muscle part of it. It has the valves, the electrical conduction system. So cardiovascular health is more than just the plumbing. Is a organ, is a living, a beating organ, and has to be taken as a whole. And cardiovascular health prevention, can start today, and needs to be addressed in the different aspect of it. And that's my talk. Thank you very much for your attention. I'm here to answer questions and engaging in dialogue with the audience.
Dr. Zhao, thank you very much. You had added some extra slides that I think would be helpful to have you go over those before we get into each Cheryl and Joy sharing their personal stories. Would you mind going over your extra slides?
Oh yeah, okay. Let me go back to sharing again. Okay. Can you see the screen well?
Yes.
Okay. All right. So I do have some extra slides I want to put in here. One is, if you do have angina or chest pain or unexplained short of breath, the doctor may refer you for a exercise treadmill test. That's ETT stands for, right? Here, the diagnostic accuracy of the different modality of the stress test, they are lower in women than men. They're lower in that we use angiogram as a gold standard, right? So if you have a positive stress test, which means you go on a treadmill, the EKG looks very abnormal, and we refer you to get angiogram, which means the doctor go in and take extra pictures of arteries, and voila, actually there's probably 1/3 of the patient referred for positive test, and they will have normal coronaries. Okay, so that's why we think the stress test is less accurate in women. But the problem is we use probably the wrong reference gold standard. The invasive coronary angiogram, we can only see by naked eye. It's very, macroscopic. It's not like, we essentially, the doctors use their eye to look at which segment of the arteries are blocked or narrowed. Okay, so a lot of the things we cannot see with the angiogram, such as microvascular disease, so disease that can affect smaller arteries, not visible, without visible blockages, can be detected by the gold standard, right? So there is emerging research and data saying that, if you have a positive stress test, you have good, very ischemic symptoms, and we don't find visible blockages in your arteries, it doesn't mean that the stress test is wrong. It's just that we are not detecting the smaller artery disease, what we call microvascular dysfunction. Okay. All right. So that's what the stress testing here is. It's kind of misleading to say it's not accurate. It is accurate. It's just we're not seeing the smaller disease that can be detected from coronary flow reserve and other more study that not available in traditional cardiac cath lab. So effect of smoking. So if you smoke similarly as men, you do have a higher risk for MI compared to women. And here's about different substance, like nutritional supplements, right? It's a very busy slide, and you have the reference there. Which one should I take? Calcium? Should I take vitamin D, vitamin E, vitamin C, vitamin whatever? Coenzyme Q10. Like there's resveratrol. There's grapeseed. There's garlic oil. There's deep fish oil, there's DHA, yes. What should I do? What should I not do? So this is a very busy slide, but by and large, it's very hard to detect any real cardiovascular benefits from supplements, and they're not regulated by FDA. They're not in the drug category. They're essentially nutritional supplements, not subject to the same regulatory requirement as medications and drugs. Actually, people have looked into, studies have looked into what supplements have relevance to cardiovascular health. And by and large, you can read the fine print, but overall, I think the fish oil is very borderline, right? Fish oil is borderline in terms of leading to any real difference. I think that fish oil is, I do believe in the cardioprotective effect of fish oil. It's just that the dose in the supplements is just not high enough to have any meaningful outcome differences in a short study period. So I think fish oil is borderline. Coenzyme Q10 has some potential benefits in alleviating symptoms from, particularly with statins, and folic acid in terms of stroke. But that's mostly from a study from Asia, where folic acid is not fortified in their flour, and so in America, the flour you buy from Costco, you bake your cookies from, they're fortified with folic acid, so may not be as relevant in this country. So that's dietary supplements. And my last slide is on how much alcohol should we take to affect cardiovascular health. This is a very telltale diagram. The bottom line is the classic, you see that also with the exercise, right? So there is a optimal amount of alcohol you can drink. This is essentially a summary but on average for women, if you have 5 to 7 drinks per week, and for men is 10 to 14 per week, there may be some in general benefit for cardiovascular mortality. The study is an aggregate of different studies, so it doesn't differentiate red wine versus beer versus vodka versus whiskey versus spirits. So it just all standard drinks in aggregation. There may be a sweet spot here in the middle. You consume some alcohol and can affect some cardiovascular mortality benefits. But on the other hand, as I said, the heart is not just the muscle or the plumbing. It also has a very robust electrical system that's very much not like any drop of alcohol. Starting from 0 is a linear straight line up. Any drop of alcohol is poison to the electrical conduction system. It can is very well known, recognized risk factor for atrial fibrillation. Is a disease that we're really in the epidemic of atrial fibrillation. Half of my work is to deal with atrial fibrillation, not with heart attack. It's a very chaotic rhythm that can be brought on by heart attack, heart failure, drugs, toxin, overweight, sleep apnea, and also very well recognized as alcohol. Every single drop of alcohol will linearly increase your risk of having atrial fibrillation. It's a lot of trouble to have atrial fibrillation. You can have heart failure, and also it increase your risk for stroke 5 times for atrial fibrillation. So if you ever think about consuming 2 glasses of wine to benefit from the quote unquote benefit from the cardiovascular mortality standpoint, but also be aware that every drop of alcohol will poison your electrical system and put you at a higher risk for atrial fibrillation in a linear fashion starting from 0 drop. That's all my extra slides.
Okay, wow, that's just fascinating. Thank you, Dr. Zhao, for your presentation. Next, we have Cheryl Lamb that's going to be sharing her personal story.
Thank you for letting me share my experience with all of you today. I've been in workers' comp attorney for about 15 years, and I 8 years in a private practice doing family law and also personal injury. And first of all, as a woman in my 50s, I have my share of health issues throughout my life. And also as a working mom with a busy law practice, I often tend to, ignore any symptoms or procrastinate going to the doctor. I'm sure some of you can, relate to this. About 6 or 7 years ago, I was having, chest pain, and I ignored it to either just a shoulder injury, or that it's just my long-standing GERD, or that it's just maybe generalized, left breast tissue pain. And I had plenty of things to rationalize that the chest pain was just anything but a heart issue. And then one day I was doing an intake for a client that had a heart attack. And it turned out the client ignored the symptoms for quite some time, and of course ended up having a heart attack. So as soon as I was done with that intake, I went to see my doctor right away. I did not want to be my firm's next workers' comp claim. Anyway, the doctor, of course, when I got there, thought that it was just any other issues and just brushed it off. And they did an X-ray and sent me home. And of course, I left not knowing and not having much answers. And of course, several months later, as this pain persisted, I started having numbness, tingling, palpation, and so forth. So went back to the doctor again. And this time they did an EKG, and I learned that I have premature ventricular contractions. And the doctor said, well, that was very common, and sent me away. But I still wanted to know more information and really insisted on additional testing. And I think when the doctor realized that I was not going to, leave until I got, additional testing and so forth, I was finally referred to have a treadmill test and sent to a cardiologist. And when I went to the cardiologist, I learned that it's very common for symptoms like GERD, shoulder pain, and stress to be that they are masked, real heart issue, because you think it's that, but it's actually heart issues. So it's very important for all of you when you do go in to insist on all the testing that you need, so that you're not, as Dr. Zhao say, emergency AF and so forth. Also, another thing that I've learned from meeting with the cardiologist is that, I'm from Vietnam, and that people that are during the time I was in Vietnam during the war, that a lot of people that are exposed to Agent Orange, they have elevated risk for ischemic heart disease, and that can cause sudden, death. So I encourage any of you that are in Vietnam at that time, or know of anyone that's been in that time, or anywhere in the world that Agent Orange was used, to go ahead and follow up with the doctor for any heart issues that you have. And I'm happy to say that for now, I don't have any major heart issues. And thank you, Dr. Zhao, for all the information. So now that the next time I go to the doctor, I have more, have better questions and more ammunition to go ahead and get the testing and information that I need for my heart issues.
Well, thank you so much, Cheryl, for sharing. All right, Joy, would you please share your story with us?
Good afternoon. I learned so much about heart from this seminar and its preparation. Thank you, Dr. Zhao. I truly appreciate all the information. So we all have a self-profile for ourselves. And my own was that I am fit joy. And that's my profile, fit joy. Fit because I participated in several state and national tournaments, continued to play racquetball, continued to hike, bike, trek, go to 20,000 feet, and joy because that's my name. I'm a happy person. So with all that happiness, one day I boarded a flight to Hawaii. I was going to Hawaii, and about 2 hours en route, I had severe chest pain. So severe that I couldn't tell the person next to me that I'm not feeling well, do something about it. When I believe I passed out, but when I came back to stability, I asked for aspirin. Very wisely, I landed, went to the hotel, full of fatigue. I was so fatigued. Next day, I decided to rest. And then life was as usual. I did not go to any emergency room or any doctor thereafter upon coming back. I just kept on living. The next time I am at a friend's house laughing away loudly 2 years later, and I thought my heart did not do well just by laughing. So I went to the doctor. That is when I went for all the testing. And then he said, I can't figure out what's wrong with you. Something is wrong with you. So he put me through angiogram. And then we realized that I have abnormally normal heart. The heart is a heart muscle and the arteries and veins. And I managed to not have the left main coronary artery, but a fully functional house. So I have no medication at that point in time, no procedure, go home and be happy again. Happily, I am spending my life working hard, and I am now settling my first $1 million case. And well, I thought, I think I should go to the doctor. My cardiologist asked me if I was very stressed. I told him, no, I love my work. I'm overworking, but I absolutely love it. He says, sorry, your heart is not cooperating and not feeling that way. The only instruction I got at that point in time was to seriously meditate. No medication, no procedures. I move forward and I'm playing racquetball. This is pre-COVID, about 10 years ago. And I am at Los Angeles board running back to LA Fitness because I have finals of racquetball tournament. I did not much eat. And I said, let me have a nice cup of coffee, large cup of coffee and an apple pie. I went to play. I played, I won the tournament. It was a men's C league. So you know what goes in there. But afterwards, that night and next day in the morning, my heart just would not stop. It was at the same beats level as I was playing at the tournament. I again landed at the cardiologist. That's the time I gave up coffee, tea, chocolate, all the soft drinks. I still am on no medication. I still am normal. I still am going to climb. Everything is fine. But what I learned, first time there is feeling of unwellness, run to the doctor. Don't take life lightly. In retrospect, I cannot imagine I didn't go to emergency room in Hawaii. That's terrible. What could be more than having such excruciating chest pain? But I didn't. I learned to balance body and mind and a work-life balance. Try and work 40 hours. Don't club the calendar too much. That's my takeaway.
Joy, thank you so much for sharing an incredible story. Thank you. Well, Dr. Zhao, we have a few prepared questions for you, and then we'll go ahead and turn to our audience. I see there's several posted there as well.
Yeah, of course.
So, Dr. Zhao, often women's symptoms aren't taken seriously. Perhaps we're not taking ourselves seriously, or as we discussed in our preparation for today's webinar, ER doctors will oftentimes profile us when we come in to the emergency room. How do women best present valid medical complaints to avoid misdiagnosis or overcoming gender bias?
Yeah, I think from the perspective of a doctor, and particularly ER doctor, I have the utmost respect for my ER doctor colleagues. I think they have the probable job to do, and they don't know much about cardiology as a cardiologist. They don't know as much about I as an ophthalmologist, and they don't know as much about joints as an orthopedic doctor, but they know about everything. And they're really faced with the improbable task of, triaging, differentiating, stabilizing, and managing. So I have a lot of respect for them. And so how, can women, when they have cardiac disease, I think there's essentially, two things to do. One is, as you've been, as Joy and Cheryl have alluded to, that women have to take their own health, cardiovascular health seriously. Like, for example, if I'm having chest pain right now, I have 10 different reasons to talk myself out of going to seek care. I'm like, I'm too busy. I have to get Johnny to soccer practice. I have to, cook this. I have to pick up prescription from my mom. I have to, finish my notes. I have my patient waiting for me. There are 10 reasons why I should not be doing the right thing, which is to seek care. And you should get into the habit that you be in tune with your body. And once you cross the threshold of 50 or even 60, and that is when the body needs a little bit sort of tender loving care. So be in tune with your body. Take yourself seriously first, okay? And when you present, for example, if you do have chest pain or chest pressure, or you're not sure what's going on, but something is not right, take yourself seriously. Take yourself either to the emergency room or take to your regular doctor and share with them your concern. And if you, every single emergency room has this chest pain algorithm. If you say your chief complaint, your CC, your chief complaint is chest pain, you will be taken seriously, okay? So rest assured, I don't want everyone to go home saying, if I go to the emergency room, I'll be overlooked because I'm young, I'm a woman. Everyone come to emergency room. If you have chest pain presentation as a chief complaint, you will be taken out of line to get your vitals taken, your EKG taken, and your symptom assessed. So maybe one thing to do is to be clear about the timeline and your symptoms, okay? And the second thing is, if you're having excruciating chest pain, make sure you get an EKG done first, and we do recommend serial EKGs, particularly when there's change in your disease. The tempo of the symptoms change. That's the time to repeat another EKG. Okay, not just for women, for anyone coming through the emergency department, right? Anything changes is a time to do another EKG. So if there's no signs, worrisome signs in the previous one, at the time when the symptom changes or more severe, that we may be able to detect something more serious to act upon. So I think take yourself seriously, present your symptom clearly, and at the time you may have to advocate for yourself, because the ED doctor is spread thin amongst all the different priorities. And in terms of the bias against women, explicit versus implicit from the providers, it has this historical root, right? Because the deeply ingrained conception that women present late than men, right? There is a 10-year lag in women presentation. So if you're like in your late 40s, early 50s, people may not take you seriously, just purely based on the population standpoint. But population is one thing, individual is another thing, right? So down to each individual patient, it may be real. And also the fact that there's lower chance of finding obstructive coronary disease once we put the patients through angiogram, right? So is that because the symptoms not real? The symptoms are real. The test traditional label as false positive, the stress test, but only because we're using the wrong gold standard. We're not detecting the small vessel disease, the microvascular dysfunction, the level that we cannot see with the naked eye. I think that paradigm is changing, not because I think a lot of providers are still in the process of catching up. So you may have to advocate for yourself, take yourself seriously, advocate for yourself when the symptoms are severe or changing, request a retest, okay, reassessment.
Okay, thank you.
My long-winded way of answering your question.
That was great. Cheryl, did you have a question?
Yes, I do. Doctor, is there a screening that women can have done to determine if they are susceptible to heart attacks? Any kind of cardiovascular screening, blood work? Well, of course, you mentioned EKGs earlier.
Yeah, that's a great question. Let's go back to the primary prevention pyramid, right? So you don't want to get to the secondary prevention, which means you already had the disease. Heart attack has already happened. We're just playing catch up and patch up the holes. You don't want to get there. You want to stay in the primary prevention preclinical stage. How can we predict who is likely to progress to have clinical manifest disease and who is going to stay where they are? Okay, so we do have, so if you're over age 40, if you have, for example, some of the risk enhancers, right? If you're a smoker, you have a family history of premature cardiac disease, like women less than age 55 and men younger than age 55, early heart attack, early stroke. 65 for women and 55, that's qualified as a positive family history. And if you have those issues, you may want to talk to your doctor about how to step up your primary prevention strategies. And for general public without smoking history, without positive family history, you just want to see where you are in terms of your general cardiovascular health. You may ask your doctor you may actually do it yourself. It's something called a pooled cohort equation, ASCVD risk calculator. You can go in online, you can plug your information yourself and see that's where the less than 5%, 5 to 7.5%, 7.5 to 20%, and 20% and above come from, right? So you can see where you play into that, which bucket do you belong to, right? If you put in your age, your ethnicity, your cholesterol, your blood pressure, your diabetes, your smoking, that's all the major the indices assessed in the it's called PCE, pooled cohort equation. If you're over 20%, that's considered high risk, and the doctor may need to do additional work. If you're less than 5%, if you have no risk enhancers, you're not a smoker, you don't have any family history, and you are not from a Southeast Asian descent. Southeast Asian in particular, not including Vietnamese, mostly the Indian subcontinent. That's very early premature onset of CAD in the Indian subcontinent. So if you have no family history, no smoking history, and you're not from India, Pakistan, or Bangladesh, and if your risk less than 5%, you're pretty set. Just keep doing what you're doing.
So I am going to take Dr. Joy Dolakia, a question from Q&A that relates to my question as well. The question is, heart disease runs in my family. Which tests should I have done that are more thorough to see where my heart is at? The attendee did not write the age, but may we assume the age to be almost premenopausal at 50, and please give us the risk factor and how should we go for testing?
Yeah, so if you're young and healthy and without any complaints, you have some risk enhancers. For example, again, smoking, right? A family history of less than 65 for women and less than 50 for men in your family with early heart disease. And if you have, so for example, South Asian descent, and you're worried about your age 40, right? Traditionally, at age 40, you shouldn't even worry about CAD, but because of the risk enhancers, you want to make sure that you don't progress to clinical disease. What would you do? Again, you can plug your profile into the pooled cohort equation for ASCVD prediction, and additionally, you may still rank very low in the risk, but you can say my mother, my dad had his first heart attack at age 45. I know my traditional risk factor is good. I'm just still worried that I may progress just like my dad, right? So in the presence of risk factors, you may ask your doctor to order like something like a treadmill test, which is not unreasonable, but oftentimes fine. But you may also want to order something called a coronary calcium score. It's just essentially a helicopter view looking from 10,000 feet above to look at the heart to see how much calcification has deposited along the coronary arteries. Is a very rough estimate of atherosclerosis. So coronary calcium scores you can do, but only for people with intermediate risk or with risk enhancers. And you can also look at some of the inflammatory markers and like lipoprotein A, which is a cholesterol component that has been shown to predict additional risk for CAD in addition to LDL cholesterol. So lipoprotein A is another sort of marker you can check to further risk stratifying the low and intermediate ones and see if we can drag a few of them into the higher risk category. See what I mean? Yeah.
Thank you.
So coronary calcium score and lipoprotein A if you have some risk enhancer factors.
Thank you.
As a matter of fact, I have a lot of Indian patients like tech workers, right? And they brought the parents over, and I see a lot of those parents and very high prevalence of coronary disease. And I've gotten into the habit of talking to not just the patient but also their children, like the 45-year, like they usually tech workers, tech executives. They're healthy. I'm like, you're in your 40s, right? Go ask your doctor for a coronary calcium score. Make sure you don't have a heart attack at work because they're usually pretty busy and stressed out. So I've gotten into the habit of giving sort of solicited advice to the patients, adult children, saying you're belonging to the high risk category because of your ethnicity. Go and check it out with the coronary calcium score and check your lipoprotein A and see if you need to start a statin.
Thank you.
The next question is from one of our attendees. Does life scanning help to diagnose any issues with the heart?
The what scan? Sorry.
Life scanning.
Life scanning.
Life scanning. That's just the question.
Life scan. If you're referring to a whole body scan, or I don't understand.
Joy's nodding the head, so let's just assume it's a whole body scan.
It's a whole body scan. Yeah, that's a great question. You know why? Because we do, a lot of patients get CT scan of the chest, CT scan of the upper abdomen, and they can capture the heart, right? So what do we do with that information? Used to be just thrown into the garbage. People like, you're here to scan your lung to see if you have pneumonia, right? You have a CT scan of the chest. And we do look at the heart. And in the past, radiologists don't even report the heart. But over the years, and actually those non-dedicated chest CTs have provided a lot of incidental information on the heart, with just beginning from both the cardiology field and radiology field. And those incidental coronary calcification identified on CT scans not designed for the heart, they have been studied to say they hold the same prognostic or diagnostic information as a dedicated coronary calcium scan. For example, if you getting your CT scan for the chest because you have pneumonia or extremely short of breath, and the heart is smack in the middle of the CT scan, and they can look at, even though the scan is not dedicated for the heart, is not gated for the heart because the heart is beating, right? So the image quality is granular, not as refined as a dedicated cardiac scan. But you can still, if there's calcification up and down the pipes, right? You have blockages there, and so our hospital and many other hospitals have begun to report incidental coronary calcification identified, and that is very important piece of information. So much so that, if I have a patient come to the hospital and I've been called for a consultation and say, oh, this person has chest pain, we're not sure which way to go, and I pull up their non-cardiac CTs, I look at the coronary calcification, voila, if there's rock piles along the corner path. I'm like, oh my God, my alarm just went so much higher. So it's a very good question. Yes, if you have incidental finding of coronary calcification on non-cardiac scan, they provide a ton of information that should not be ignored.
The attendee has asked a question that 2 glasses of wine accelerates her heart rate. You have any comment on arrhythmia?
Yeah, as I said, I think that the diagram illustrates really well. Red wine has been touted as cardioprotective, but I think wine, coffee, to the same extent, they're kind of like analogous to each other. There are many epidemiological studies, observational studies saying that people who drink coffee will have better cardiovascular health, and but we know that any alcohol intake, any caffeine intake will have a negative impact on your conduction system. You will have more palpitations, and you will have higher risk of atrial fibrillation. So if it makes your heart beat funny, you should scale back, okay? Because alcohol heart syndrome specifically refer to arrhythmias and atrial fibrillation. And the heart doesn't, the electric system in particular does not like alcohol or even coffee. So if you come to my office, come to any doctor's office complaining of palpitations, one of the first recommendations is to scale back on caffeine intake and also stop using alcohol. Yeah. So if it makes you uncomfortable, stop using it.
The next question we have is from one of our attendees is, can we naturally break a metabolic weight without GLP-1?
Yes. Yeah, you can. Yeah, I sort of put it up there for the obesity set point theory, because I think people who cannot shed weight, they have a lot of guilt and self-recrimination, and doctors look at them, they may also experience some negative perception by others, including provider, like either from the not working hard enough or not having enough strong enough willpower to stay away from the guilty food, right? So there's a lot of guilt. I do want to. That's why I put the slide up there as a teaser that there is a theory that there's some physiology or biology you may not be able to fight just with the willpower. So yeah, so the ideal body weight is using BMI, a body mass index, as a simplistic, overly simplistic, but the best index we have so far is 18.5 to 25. Okay, so anything less than 25, if your BMI is 24, 20, 23, 25, you think that you look a little bit on the plumber side, as long as you don't have metabolic syndrome, your cholesterol is okay, your blood pressure is okay, your sugar is okay, you don't have fatty liver, 23, 24 is okay, right? Anything less than that is cosmetic. But if you are in the lean diabetic, profile, like your body is not, you don't have obesity, but your metabolic profile is deranged. For there's a lot of Asians, they're perfectly normal looking, like they're thin, their body mass index is like anywhere from 20 to 23. They're not at all obese. It's just metabolically they're a mess, right? Their sugar is out of control, their lipids out of control. They have fatty liver. Their liver function tests are wacky. So in the absence of those biochemical derangements, I think anywhere from 18.5 to 25 is doable. And if you just are not above the limit, and you can certainly do all the right things, eating healthy, daily exercise, 30 minutes moderate exercise a day for 5 days per week, and eat healthy, and eat the right food, eat the right portions, and using maybe intermittent fasting, limiting your feeding window to say 8 hours of feeding and 16 hours of fasting for 5 days per week. That's enough to bring your body into the normal range. And the GLP-1s, the medical therapy, is for the what we call class 3 obesity if your BMI is over 40 or 45. So that's more, it's very hard for that category of obesity to drop from say 300 pounds to 150, right? So that it's a lot of biology you cannot fight alone. You have to resort to some pharmacological help. So if you're just like 26, 27, you're maybe 20 pounds over, that's something that you should be able to do just with the change your lifestyle. I hope that answers the question.
Dr. Zhao, thank you so much for being here with us today. We truly appreciate your time preparing for this webinar and taking questions from the audience. Cheryl and Joy, thank you so much for sharing your personal stories. As women, we're the master jugglers, juggling careers, families, being caregivers to our kids, spouses, partners, and parents. Let's make our heart health a priority with the lifestyle changes, focusing on life's essentials 8, or the ABCDE checklist that Dr. Zhao taught us earlier today. Let's listen to our hearts. Thank you all for taking the time to be here with us today. We wish you well.
Thank you for having me. I'm honored. Thank you.
And Heather, thank you so much for the tremendous amount of time and effort that you put in this heart seminar today.
Oh, thank you.
That's me to tell everybody that I am 63 years old with abnormal heart, but my rated age is 6 years younger. So we can do it. Let's do it.
Let's do
Life's
it.
essential 8.
Thank
Yeah.
you.
So primary prevention, I hope all of you will practice healthy living and will stay at the primary prevention stage without any progression.
Thank you.
Yes, thank you. It's never too late.
Never too late. Okay,
Okay.
prevention. Yeah. All right.
All right. Thank you
Thank you
all.
so much for having me today. Bye.
Thank you. Bye-bye.